Good morning, delighted to see you all. I know we have others still filtering in, but wanted to go ahead and get started with announcements and introductions. Welcome to Medical Grand Rounds. Very important announcement and reminder for next week. Next week is our Benson Kendall Lectureship, which is a shared lectureship among all 4 teaching programs in Portland. And so our Grand Rounds will be at noon next week, actually starting at 12:15. Please be sure to come. Dr. Nishimura from the Mayo Clinic will be here discussing pericardial disease, a new look at an old disease. I believe there will be some lunch provided. Today, I am delighted to introduce the first annual Richard Warnick Memorial Lectureship in Medical Education, particularly near and dear to my heart and many of us I know. Richie, after completing his fellowship in Dallas, Texas in rheumatology, joined the Providence Portland Medical Center faculty where he was beloved for 37 years. He's been recognized as an outstanding clinician educator to learners not only at PPMC, but really to those of us at other programs and throughout the state. He was humble, perhaps to a fault, and had a certain disdain for awards, but nonetheless was the recipient of many, including the Providence Portland Teacher of the Year, the Sister St. Vincent de Paul Award for Leadership in Advancement of Diversity, as well as the Oregon ACP Chapter Award for the H.P. Lewis Distinguished Teacher and the 2016 Laureate Award. He presented at well over 100 conferences, published more than 60 academic papers, and was truly an elite teacher of evidence-based medicine. His generosity was unsurpassed in his teaching, and I know that he influenced the care of many, many patients who certainly never even knew his name. And as many of you know, and I particularly do, he truly shaped continuing medical education within Providence, allowing us to bring just outstanding teachers and lecturers of the highest quality from around the nation to serve us here in Portland. And today is an example of that. And so I am delighted to introduce today's speaker, Dr. Susana Morales. She's the Vice Chair of Diversity, an Associate Professor of Clinical Medicine, as well as Associate Program Director in Internal Medicine at Cornell Medical College. Dr. Morales obtained her medical degree from Columbia and then went on to do residence training in internal medicine at the Presbyterian Hospital of the City of New York, where she joined the faculty of the Division of General Medicine and served as a prominent clinician educator in several areas, including coordination of primary care education efforts, and co-directed a student course focused on psychosocial issues in medicine. In addition to her other roles at Cornell, she is the PI and director of the Diversity Center for Excellence. And Dr. Morales has served in many roles nationally, certainly in a leadership capacity, including the Council of the Society of General Internal Medicine, as well as a member of the Commonwealth Fund's Bettering the Health of Minority Americans Advisory Board. She's been a true champion for the advancement of public health, as well as diversity in medicine. She herself has been the recipient of numerous awards, including the J. James Smith Memorial Award, presented annually, chosen by the Cornell House staff to honor one of their faculty who exemplifies the qualities of teacher, scholar, and physician, as well as the National Medical Fellowships Community Service Award, presented for extraordinary commitment in the area of public health. Please join me in welcoming Dr. Morales.
Thank you for that beautiful intro. I think I have to stand out here because I'm really short. And I couldn't see you, so I imagine no one will be able to see me. I'm really honored to be here today. It's 11 o'clock my time, so I'm really impressed at all of you early birds, because I feel wide awake. And this is the first time I'm in beautiful Portland. My niece, my cousin's daughter, who's like my niece, lives here now, and she was explaining to me that this is a temperate rainforest, and it is truly beautiful and lush. Ruth was also explaining to me, though, about the landslide, so that made me nervous. But anyway, I'm going to be speaking today about diversity in medicine. It's the 1-year mark of our Diversity Center of Excellence grant, which I'll tell you about. But I did want to acknowledge that I'm really, truly honored to be the first speaker for Dr. Wernick's memorial lectureship. I never had the honor of meeting him, but I know that he was truly valued and loved by all of you, and his legacy as a teacher and scholar, I know, lives on through your work. I know it's raw because it's only been 8 months, I realized, so this is truly a special honor to be the first one to speak in this lectureship honoring him. What I want to do today is to review the rationale for diversity in medicine, a little bit about health disparities, justice and equity in health, identify some factors affecting minority admissions to and success in medical school, discuss some issues affecting minority representation and success in academia, a little bit about mentoring and diversity, and discuss some strategies to enhance diversity in academic medicine, including some of the efforts that we've been making at Cornell. As we know, we are becoming a more and more racially and ethnically diverse country. And the United States population is right now, as of 2010, was about, 40% non-white. It's projected that by 2040, it'll be majority minority. And one of the challenges is that minority populations suffer different outcomes in health. But we believe that greater workforce diversity can increase access to high quality healthcare services. Part of that is because minority physicians are much more likely than white physicians to practice in underserved communities and to treat larger numbers of minority patients, are also more likely to enter primary care. And for those of us in general medicine, that's an important fact because of our primary care health workforce shortage as well. African American and Latino physicians, as well as women, are more likely to provide care to the poor and to those on Medicaid. But the dilemma, of course, is that there are marked racial and ethnic disparities in health status and bias on the part of providers, mostly unconscious or implicit, and more importantly, I think, on the part of healthcare systems and structures that are some of the causes. And that I feel, and I think, and others have felt, that a diverse health workforce can help to mitigate all of these factors. In addition, because of our multicultural society, it's felt that healthcare providers need a firm understanding of how and why different belief systems, cultural biases, ethnic origins, family structures, and other culturally or socially determined factors can influence the manner in which people experience illness, adhere to medical advice, respond to treatment. Certainly right now, we are in New York City and here in Portland, there is an outbreak of measles, and issues around trust and beliefs are in the forefront for all of us. I think that a diverse student body can enhance the cultural competence of all students, of the health, of residencies, of faculties, that everybody benefits when we have diversity. Certainly, lots of literature about the way that diverse teams, both in business and education, change the outcomes and make better decisions. A diverse researcher workforce can be key to setting the research agenda and designing appropriate interventions. And the distrust of medical research, in part because of past abuses, can be mitigated by a diverse researcher workforce. So there are a lot of different reasons that we need to have greater diversity in our health workforce. And as I mentioned, of course, minorities and poor people in our country face poorer health status, both poorer health outcomes and disparate treatment within the healthcare arena. So that the most gross differences in vital statistics include differences in life expectancy, the gap, what's interesting to me is that the gap has always been there, and I guess it narrowed slightly, but there still remains a marked gap by both gender and race. Another interesting fact, though, is that Latino life expectancy is actually longer than other groups, and that's something that we don't have time to go into today, but that's something called the Latino paradox, or the Hispanic advantage. It's also something that you see with immigrant populations, that there is, and it's not necessarily only because only healthy people migrate. That's been disproven. It seems that there is a healthy, potentially healthier lifestyles and other factors that then, unfortunately, the second and third generations do worse. And so one of the challenges as we become more diverse is that we don't want that to happen. But one of the other interesting things is there's so much negative news about a lot of health disparities literature that when you find something that is actually protective, it's really interesting, right? You kind of think about, how do you bottle this? And so, you know, we don't quite understand the whole story, but it's interesting. There are differences, gross differences in infant mortality by race and ethnicity, especially for African American babies. So twice the rate of death in the first year of life. There's a lot of attention being paid now also to the longstanding disparities, I don't have a slide on this, in maternal mortality, especially in African American moms. And I guess the other thing that's important to mention here in terms of infant mortality is that usually all Latino groups are lumped, but actually when you, and actually the outcomes are actually good. Again, another Latino paradox, Hispanic advantage thing, because in terms of the other social determinants of poverty, lack of education, and so forth, Latino groups are similar to African Americans. So it's paradoxical that the outcomes would be so different. But when you break down the groups by subgroup, there is a difference in subgroup. And so Puerto Ricans, I'm a Puerto Rican woman, have much worse healthcare outcomes. And that's another complexity related, I think, to a lot of historical factors and so forth. At any rate, what the backstory, and I should have put it in at this point, but I put it in later. We began a Center for Health Equity at Cornell a couple of years ago, and which a lot of institutions are doing. But I think one of the benefits of that notion of sort of institutionalizing a concentrated approach to health equity, and there are different people that may be interested in different facets of health equity. And it's like a virtual center. We don't have like a building that we're all sitting in. But the idea for us was that. And this was my division chief, Monica Safford, who came actually from University of Alabama. She proposed that we start a Center for Health Equity. And the concept grew from, initially it was just going to be in our department to, and then it was going to be the medical college, but then it became a Cornell-wide center. And the notion in part was that to really think about issues of health disparities and health equity, you need to have not just doctors, because most of the issues are not healthcare delivery, but you need the economists and the sociologists and the nutrition people and all the other folks to work collaboratively. And so we have now a Cornell University-wide Center for Health Equity working on and collaborating in these areas, and it's been really exciting. And as part of our efforts, we decided that we would apply for a Diversity Center of Excellence grant, which we ultimately received. But as part of that, we actually did a deep dive into thinking about a needs assessment, like you usually do when you think about grants. And so part of what I'm going to tell you about is some of the data that we looked at locally. So first of all, the fact that in New York State, a pretty progressive state with pretty progressive health care access laws, but notwithstanding, we have a very, very extremely diverse state, of course. Latinos and African Americans, which we focused on because of the poor representation in the medical workforce, make up about a third of the population of the state, but have disproportionately poor health outcomes in comparison to other New Yorkers. In particular, African American New Yorkers had much higher total mortality rates, death rates from heart disease and diabetes, and other markers of dilemmas like teen pregnancy and higher infant mortality. And in New York City, where our highest biggest killer is heart disease, African Americans and Latinos were more likely to be hypertensive, and African Americans had the highest age-adjusted death rates from heart disease. But in addition, heavily minority and also poor neighborhoods in New York City also had much higher cancer death rates. And I don't have a slide about this, but one of the issues in New York, and I think in many, many other localities, because we are such a both racially and ethnically and economically segregated country, you can have, a difference of a few blocks mean a huge difference in healthcare outcomes, so that there's a 10 to 20 year life expectancy difference between one neighborhood in New York City compared with another. So when you look at some of the social cultural determinants, we have a lot of course, foreign-born people. About over a third of our population in New York City is foreign-born. Half speak a language other than English at home. And we have major educational challenges, including the fact that minority New Yorkers are much more likely to lack a high school diploma, for example. And then in terms of the limited English proficiency and health literacy issues, we know that people with LEP and low health literacy are less likely to use health services in general, but also demonstrate poorer adherence to medical advice, possibly at least in part because of not understanding it, and poorer health outcomes. And that language concordance between providers and patients is most likely to lead to better communication and health outcomes. And that professional interpreters can be effective. Once upon a time, when I was in training, there was no such thing as professional interpreters in our hospital in Washington Heights with like a huge Latino population. Like I was the interpreter. Now we do have a professional interpreter system, and I think most places use a lot of telephonic interpreter systems. But professional interpreters are, of course, essential, but they may not be as effective as language concordant providers. And then, of course, you have the problems of access to care. In 2014, about 11% of New Yorkers were uninsured, which is better than a lot of the country. But almost half of the uninsured in the state were minority. And even if you're insured, obviously that's different from having your own personal physician or usual source of care. And minority New Yorkers were much more likely to report a fair or poor state of health. And a lot of the issues, I think, related, explaining some of the disparate results have to do with poverty. So minority New Yorkers are much more likely to live in poverty than others. What are some of the other factors? Well, mistrust. Mistrust of healthcare institutions, which, as I mentioned, is like a big topic right now, and health professionals continues to be a major challenge in many communities, but definitely in minority communities. And abuses like the Tuskegee syphilis study, sterilization abuse in Puerto Rico, and segregation all contribute to decreased trust in medical research and in physicians, and higher rates of medical non-adherence. So a larger minority workforce can help to bridge the gap by helping to provide culturally sensitive patient-centered care. In terms of the healthcare workforce, and sorry, this is kind of a busy slide, but in 2013, out of all active US physicians, about 8% were either African American or Hispanic, compared to the 30% of the population, overall population that's African American or Hispanic. And even in New York City, 12% of doctors were minority, even though half of the New York City population is African American and Hispanic. It is felt that by some that concordance may help change the outcomes. Now, there's no way that we could have perfect concordance, nor do I believe that that is necessary to change the outcomes. But minority physicians are more likely to care for poor minority patients, as I mentioned, and so expanding the workforce could increase access to health care. But what are some of the challenges? Well, Black applicants to medical school have much lower acceptance rates than other applicants, and the number of matriculants to medical school, and this is divided by race, so African American and Latino are down here, has remained essentially flat for decades. So despite many efforts to try to enhance enrollment in medical school, there has not been a huge change. And then in academia, we are very poorly represented. Only 4% of full-time faculty are of any underrepresented group as listed. And of course, even though at this point, at least half of medical school matriculants are female, we still have underrepresentation in academia, and not represented here, but especially in the upper echelons of academia, so that women are entering medical faculties but are not necessarily ascending the ranks at the same rate. So there are a lot of different barriers, and the most important one really is in terms of minority entry to medical school, health profession school. The most important one is the disparate educational system in America for poor people and people of color. But in more detail, we know that kids develop interest in medical careers as early as middle school, but negative experiences in science coursework in middle and high school may dissuade minority students from considering medical careers. And low-income kids have much less access to advisement in high school, to advisement in high school, which is a crucial factor in college preparation. In addition, in New York City, which we looked at in more detail, we have one of the most segregated educational systems in the country, actually, in New York City and New York State. And schools with higher percentages of minority students and low-income students have higher dropout rates, so that we actually in New York State have a graduation rate of 33rd in the country, which is totally, when I reviewed this literature, was totally discouraging, and I didn't know. And then we have the reality that of the almost million kids in public school in New York City, 75% are African American and Hispanic, so that other families are putting their kids not in public school, and so that we have a very segregated public school system. The higher the child poverty rate in a community district, the less likely that a kid living in that district will graduate high school on time. And since a quarter of the kids in New York City live in poverty, with higher rates among minority children, that disproportionately affects minority kids. If you do make it into college, which is with all of those challenges and all of these structural barriers, minority kids are less likely to major in STEM fields. And when people look at the minority students that leave pre-med, most of them identify negative experiences with undergraduate chemistry and poor advisement as important factors. Certainly, and conversely, mentoring for college students increases the rate of college graduation. That seems like a no-brainer, but actually implementing stuff like this is very challenging. There are other barriers. Minority applicants had somewhat lower MCAT scores and GPAs, making them less competitive for admission. And many minority kids also had competing demands for their time, especially work. And I'll tell you a little bit later about some of what we've done with partnering with schools in New York City. But when I've talked with undergraduate pre-med students in our programs, most of them have 1 or 2 jobs, and they're going to school full time. So they basically are working like 7 days a week constantly. And in addition, a lot of these young people may lack minority role models, adequate advisement, peer support. They may be, sometimes they're kind of the oddball that wants to be a doctor in their communities because other students haven't actually made it that far in higher education. So as a result, I think of a lot of these pressures, if students actually go over all of those hurdles and make it into medical school, when you look at the data about our medical students, minority kids in medical school had higher rates of burnout, were more likely to be attending school outside of their home states, which may contribute to sometimes feeling more isolated and not having as much support. They may be more likely to have parenting responsibilities. And a lot of these challenges probably contribute to lower retention in academia for minority folks, making support and mentoring even more crucial. a comment about high stakes exams. Minority students, as I mentioned, tend to score lower both on SATs and MCATs. And this is probably multifactorial, but really, what most of the data shows is that these high stakes exams mainly line up with parental income. And the problem, as some critics have talked about, as for example, Gelato and colleagues in academic medicine a couple of years ago, that for much of the past century, medical schools and residency admission committees have relied heavily on MCAT and USMLEs to evaluate and rank candidates. But MCAT scores have limited ability to predict future success in clinical medicine or biomedical research, and students from disadvantaged and minority backgrounds do not fare as well and may be disproportionately excluded from the medical profession. I'm not sure if people saw, but a colleague at Yale, she's in general medicine at Yale, and she wrote with an attorney, law professor at Yale Law School, looking specifically at MCATs and how they are basically exclusionary. And what's interesting to me right now in medicine, and this is a side issue, but it's a pet peeve, so bear with me. When you look at, there are some institutions that are actually eliminating use of the SATs and some of those high stakes exams. I think University of Chicago may have the different schools because of the feeling that it doesn't necessarily reflect, it's not really a predictor, and that it ends up being just a way to slice and dice your applicant pool and potentially eliminate people that would otherwise be compelling students in your student body. I think I personally feel that we need to look critically at these high stakes exams as well, because of the way that they're ending up to have unintended consequences of just being exclusionary. So, for example, the USMLE is not supposed to be used as a way to just slice out the bottom group of your applicant pool. And yet, that's what a lot of schools do. And some of that, I think, is being done mainly for the overwhelmed situation of program directors, which I can totally relate to as an associate program director when you get a zillion applications. But the problem is, who are you actually missing by using that as your elimination criterion? Anyway, back to my central topic. Some of the things that, some of the things related, I think, to what sort of corollary to this. There are other these authors looked at how African American medical students define success. And of course, scores and grades were important, but when queried, the students also talked about other things: a sense of balance, happiness, authenticity, a desire to positively affect family and community, to serve as role models, providing needed medical care, participation in social and cultural activities, giving back to the community. And certainly I see that actually in all students, not just minority students. I've been very struck over and over by, and I don't know if there are students in this room, but I think this generation is particularly, hi students, particularly conscious of their role in society and the devotion to thinking not that I don't want you to learn about acid-base balance or whatever, but the thinking broadly about our responsibility and our role in society. And so, but certainly when you look at minority students, this is something that people also talk about. There are certain success inhibitors for minority students in med school, including lack of support, experiences of discrimination, poor cultural representation, self-limitation and self-doubt, kind of the psychology of exclusion. The financial factors, it's a lot harder to work in medical school. Most people don't, and so that people are really struggling. If they are isolated, I think that is a major challenge. And then sometimes inability to connect with members of the campus community. On the other hand, success factors can include financial aid and scholarships, social support, professional exposure, certain personal characteristics of resilience, I think can be helpful, and then faculty mentors and validation. When you look at the special focus on mentoring minority students in medical school, minority students often feel a special affinity for minority faculty due to their thirst for role models, a trusting relationship, and someone that has a deep understanding of the societal realities that are faced by minority students and minority people. And minority faculty, in turn, have been documented to feel a special responsibility for minority students and trainees. But the dilemma for minority faculty is that they are overwhelmed sometimes. So when you look at the literature there and around the country, there are a few programs that are focused specifically on mentoring minority students with the goal of retaining them in academia. And so then it becomes a vicious circle. You don't have people in academia, then you don't have people to mentor the students, and it goes on and on and on. And probably helps result in the fact that minority students may have negative attitudes towards academia. Because, as I mentioned, only 7 or 8% of US medical school faculty are African American or Latino. Once people actually jump through all those hurdles and make it onto the faculty, minorities have a higher attrition rate and are less likely to be promoted, even with similar rates of funding, publications, and so forth. And many medical schools lack any focused programming to enhance minority faculty careers. Other barriers for minority faculty include a paucity of mentors, again, because of that vicious circle, promotion bias, high medical school debt. Some of my graduates now have 300,000 plus in debt, which is staggering, especially because minority students are more likely to come from working class families or low income families, and so there is no other way, unless their school provides lots of scholarship, for them to make it through the medical school course without lots of loans. And then there's the disparate committee responsibilities, especially regarding diversity. So it's sort of a blessing and a curse. You want to be involved, you want to help, you want to do it, but yet you're doing 100,000 other things as well. And people have talked about the minority tax, the black tax, the brown tax. Now what's interesting when you look at the literature about academic faculty is that there's significant discontent amongst everybody, minority and non-minority. It's just that it's worse for minority faculty. So that's kind of a bummer. And students and residents aren't dumb, and they see some of that discontent. So that the other piece here, I think, is thinking, for us in terms of having leadership around a lot of these issues, is thinking in general about what we can do to make faculty more satisfied and happier and less burnt out. But minority faculty specifically identify difficulty with personal and family issues, and that may be related to childcare and things like that. And then other things that were described in the paper that I quote as moral distress, lack of engagement, and low institutional support. Another factor, and again, I'm sorry for the busy slide, but I'll just explain it. So diversity climate. This is obviously a little hard concept, right, the diversity climate. But what people talk about with the diversity climate institution, that includes something like the NAAMC has a whole series of papers about this on their website. But what these authors talked about is the historical legacy of exclusion in an institution, how diverse the students and staff are, what the psychological climate is, including specifically about perceptions of discrimination, behavioral dimensions of social interaction across race and ethnicity. Do people socialize outside, or is it very formalized? Is there campus involvement? What's it like in the classroom? And people talk about, in terms of diversity climate, people about feeling invisible to colleagues. You know, I was walking down the hall and people didn't even acknowledge my existence. To experience of more blatant racial bias, which many people have experienced. And so it can go across the gamut, but things like that all contribute to this notion of diversity climate, and it ends up being a really important thing. In addition, minority faculty experience decreased access to informal networking, disparate questioning of abilities or credentials by their colleagues, And the things that can improve diversity climate are, first of all, self-awareness by leadership and all faculty of attitudes and bias. Because the first problem, I think, for all of us is, of course, that we all have bias. That's something that we know. We don't necessarily, it's not necessarily conscious bias, and it's not necessarily something that we really know how to address. But the first step is our sort of accepting the fact that we all have biases. And our institutions, you know, irrespective of individuals, our institutions have postures, let's say. And that leadership making diversity a priority is really important, and increasing diversity among leadership, faculty, and staff. So for example, one of, you know, I was introduced and mentioned that I'm a vice chair for diversity. That's only been about 3 years. The position has only been maybe 6 years. I think the notion behind that is that if you make it, and you know, I've always done diversity work forever, a lot of times on my own time, but to be supported in terms of some of my time and to be, given some resources to do it, and to have me, the sort of lens of diversity on other decision-making aspects in my department is important. Medicine was the first, of course, because medicine's great, but now all of our departments either have a vice chair for diversity or a diversity champion to look at issues up and down the ladder in terms of in this area. So it is one way to try to institutionalize that approach. What are some other issues for academia? I mentioned mentoring, which we know is pivotal to career success. There are a lot of deficits in mentoring in academia, especially for women and for minority students, residents, and faculty. A lot of medical students, both minority and non-minority, by the way, report not having a mentor, and many medical schools lack formal mentoring programs. And one of the dilemmas is that they're hard to study, I think, and so there are a few proven successful models, especially for disadvantaged groups. But there's sort of formal mentoring programs, but then there's also the reality of informal mentoring. And most of us have benefited from informal mentoring. It's hard to make the perfect matchup between a mentee and a mentor in a formal way. But then then women and minority folks have challenges in terms of accessing the informal mentoring. So that women and minority mentees may feel more comfortable with a mentor that looks like them, but actually, when you look at some of the details, it's really the sensitivity of the mentor that's the most important part. That's what people actually identify. And of course, my anecdotal personal experience has been that the majority of my most important mentors have been neither female nor minority. And so I think really the sensitivity and warmth of the mentor is the most important thing. But one of the ways that one of the other challenges I think about mentoring is there's not like one perfect mentor that's like your mentor messiah that's going to solve all your mentor issues. And so really, it's why I've become interested in mentoring teams as a way to help close these gaps. The specific issues for minority faculty is that if you're already really busy, to also have to mentor everybody can be a time challenge. And luckily, though, it doesn't have to be minority faculty that do all the mentoring. For who mentors the minority faculty, though, especially when there's so few, you know, some of the success factors include training the mentors, and then on the mentee side, some of the factors that help are having mentees who are assertive and drive the relationship, and this is true for all mentees, but who have a commitment to and passion for success and are proactive and self-reflective and accept feedback. That's sort of mentoring 101. But a lot of times, many of us have been taught about mentoring, but most of us mentees haven't necessarily thought about how do I be an effective mentee. But there is a whole literature about that. A lot of it isn't in the medical literature, some of it is. But it's extremely useful to think about. The business literature, you know, in business, you have to have a mentee in the business world, and there's a lot of literature about it there. But some of the barriers to good mentoring include lack of mentoring skills, just a poor fit, sometimes it just doesn't click. The gender or race difference may sometimes be a barrier, although as I just mentioned, it doesn't have to be. As a mentor, if you're overly directive, the time constraints, if there's a conflict of interest, sometimes there's competition between the mentor and the mentee, so that's kind of a poisonous situation at times. If there's time-restricted funding, so that there's a lot of time pressure. And then, of course, if there's inadequate institutional support because it doesn't come out of the air. And a lot of times mentoring is expected to be in-kind contribution. And institutions can promote effective mentoring by having systems of multiple mentors, mentor training, and expanding mentoring pools. I'm going to skip ahead. So what are we doing at Cornell? Well, first of all, the most important thing is we've had really outstanding leadership. So Dr. Choi, Augustine Choi, is a pulmonologist who was previously at several institutions, but before he came to Cornell, he was at Harvard. He was our department chair and actually appointed me to be vice chair, so I especially like him. But he is a really visionary leader. He's incredibly committed to research and to expanding our research portfolio as an institution, but he's also been very, very committed to diversity. So we have a pretty robust diversity infrastructure, which includes Dr. Ibrahim, who's a general internist who used to be at Pittsburgh. Some of you in Gen Med may know him. Dr. Simmons, who's a breast surgeon. Dr. Golightly, who's an ID doctor. Marcus Lambert, who's our grad school diversity dean. And Liz Wilson-Anstey, who's been at Cornell for over 50 years, since she was like a young thing, and has been the director of one of our wonderful pipeline programs for many years. So there's a really strong dean's office leadership. But in addition, we have a lot of other people, because the point of this is that you can't have like one person that like does diversity, and there has to be an infrastructure. So we have a diversity council in the medical school, and the GME, Graduate Medical Education, has a diversity council. The residents have a committee, a minority house staff committee. And as I mentioned, we have a diversity champion in each department. And then we have some trans Cornell organizations like Black and Latino Men in Medicine, which residents, students, and faculty founded within our institution to address the special issues faced by minority men. That the numbers, as I mentioned, have been flat in terms of minority representation in medical school. But when you look at minority men, especially African American men, there are actually fewer numerically Black men entering medicine now than there were in 1970, which is crazy. So they have been very focused on trying to turn that around. And there are some other efforts around the country that are also similarly focused. So all of this backstory we looked at to try to have us both do a needs assessment, but also to look and see where were there gaps within our efforts at Cornell, and where were some ways that we could make a difference if we got some additional resources. So, and I mentioned about the Center for Health Equity, and that we are a bi-campus institution. So HRSA has a Center of Excellence program, the Health Resource Service Administration, Bureau of Health Workforce at HHS, that has been around for many years. And there are right now 19 funded Center of Excellence programs, including some of the historically Black colleges and universities, Stanford, Rutgers, all over the country. We're the only one right now in New York State. But the goal of the Centers of Excellence programs specifically is to strengthen the national capacity to produce a quality healthcare workforce whose diversity represents the U.S. population. HRSA and the Bureau of Health Workforce also fund primary care workforce grants. HRSA runs the Community Health Center program, the migrant health clinics, the rural health clinics, a lot of the sort of safety net programs for the country as well. So our Diversity Center of Excellence we actually applied in the beginning of 2017 and didn't get funded the first year. We were like, scored but not funded, and I was kind of bummed. And then a year later, last June, I got an email, Dr. Morales, if funding were to become available, would you be able to execute the project as described? And I was like, yes! So So the way that we that composed our grant and our project was a collaboration. That this is, like I mentioned, like one person or even one small group of people cannot really address all of these issues. That it was going to be a collaboration between all of the people that I mentioned, as well as our summer programs, our other pipeline programs that we already ran, working with our students, and so forth, working with the hospital. So one of our projects was to expand the pipeline programs that we already had, including support and evaluation for HPrep. HPrep is it's actually a national program, but it started at Cornell, that's run by our medical students for high school students from around New York City. I was the keynote at the graduation. I should have put a picture in, but I didn't. But for like 120 adorable kids from all over the city who apply for acceptance, and the students like review their applications. Like the students are like deans already. So we did that. So we're working on, but as what HREB hasn't had is as robust an evaluation process as it could. So we're trying to expand and refine that. The Travelers Summer Research Fellowship Program is another, as I mentioned, Liz Anstey runs. That's been around. We just had our 50th anniversary of that program, and it has 25 students a year. We expanded the slots, so some extra students were able to be admitted. And then, as I mentioned, the Black and Latino Men in Medicine Partnership. My idea has become that people that have an idea and want to do something, we want to support them and provide them the administrative support, because a lot of people have, that's like the best thing. So the Black and Latino Men in Medicine group went to the African American, they started their own little pipeline program this year, which was like an 8-week intensive program for high school students. And they went, one of the things that they did was go to Washington to the National Museum of American History and Culture. So that's their field trip. And they just had a white coat ceremony at the annual Black and Latino Men in Medicine Conference, which was part of our Diversity Week celebrations a couple of weeks ago. But some of the data that I showed you about the pre-med experience informed what I wrote into the grant in terms of a pre-medical initiative. Because when I thought about it, I mentioned like half of New York City is of color. There's a lot of those kids in college. Why aren't they going to medical school? And my theory was, and as our needs assessment has subsequently demonstrated, the pre-med counselors are overwhelmed, super busy, have a zillion kids on their roster, and there are a whole bunch of eager kids that want to go to medical school. So we've established some linkages between our medical college and local colleges and universities, and we've been having ongoing meetings. But one of the things we also did was have a pre-medical student conference. This is one of our mentoring workshops. We're having periodic sessions of informal mentoring called Dining with Doctors. These are college students from Fordham University, which is one of our partner schools. And then for the medical students, we've expanded the student support programs. And probably my favorite thing is the mentoring Cascade. So along the lines of what I mentioned before of teams, mentoring teams. So this was our kickoff in January. And what we've done is brought together medical students, residents, fellows, and faculty, as well as some alumni who are not necessarily at Cornell, but are in the community, but that are involved with our medical school, and either from our medical school or from our residencies, in teams of about 10 to 12 people, interdisciplinary, multi-level, because one of the challenges, I think, for all of us in medicine is that everybody's really busy and there are a lot of silos. So the students have their little silo and they don't necessarily know anyone. They don't know the residents except when they finally show up on the wards, and maybe they'll be with a resident for 2 weeks. And the faculty are running around like crazy. And there's not necessarily a place for people to come together. So we've been sponsoring, we have our setup is we have a keynote who gives a brief talk. Our first talk was about how to be a mentor and how to be a mentee, along the lines of some of the things that I was talking about before, and about developing your mentoring team, and about not necessarily all of your mentors are going to be of color, and you need to actually look and develop a team for the different parts of your future and your interests. But anyway, it's been really, really cool. And the other thing that we've been working on is having what's called proactive academic support services, because I think that if you're going to bring people into medical school, you have to support them to get through and to do well. And so we've been working with the dean's office to expand and improve the academic support for all students, but this will also benefit the minority students. We've been working on leadership development seminars and advocacy training and events with our students, and working with our minority student organizations, which include the Student National Medical Association, the Latino Medical Student Association, and we've been working on community engagement. But the other piece, I guess, is involvement of the students. So, I did all that big giant lit review and thought about all these things, but then when we devised these programs, we involved the students and residents in their creation. So this is one of our planning meetings, one of our students, thinking about what should the mentoring program include. We've been working on improving and expanding our cultural competence and health equity training, including working with our cultural competence planning group. We want to engage community members to identify training needs and develop a novel training program that's in the works. And we have a health equity area of concentration. Our students have a 6-month block of their time now. They do all of their basic science 2 years in 18 months, which is really crazy, but I think. But what it means is that at the end of their 3rd year, they start a 6-month block of research. And so they can do projects within health equity if some of them have health equity research interests. And some of our community partners include WEDCO. I used to be on the board of WEDCO. It's the Women's Housing and Economic Development Corporation, which is a multi-service agency in the South Bronx that isn't only for women, but it's for families. And they have a charter school, and they have a Head Start program, and they have a lot of other services. They have housing and economic development, hence the name. So they have like a small business incubator, and they supervise the family daycare, a big family daycare operation for training women to have family daycare businesses. And then the New York City Department of Health wrote us a letter of support as well. They have obviously we have one of the biggest and most progressive departments of health in the country, so we want to, it's actually needs to be better utilized by our medical school and residencies to embed our students and residents into their projects. They actually have a whole health equity component with health equity action centers. This is one of them in Harlem, which brings together, provides support for community-based organizations and works on centralizing efforts both in terms of healthcare access and health insurance enrollment and walking groups and all this other stuff to try and health education that's run by and with community members. We want to monitor diversity climate at our school. That's actually a bigger undertaking than I thought when we first proposed this, because every single level collects different types of data, but what we really would like to do is have data from the students and the residents and the faculty and the staff as a baseline, and then actually do something to try to move the needle. We want to increase minorities in graduate and medical education, so there's not a glass ceiling, because we actually have had a pretty decent history of, for the most part, of diversity in our med school, but then they weren't entering the residencies. So that's included having, as I mentioned, the GME Diversity Council, but we also have a couple of things. I've run a Make Your Match program, which is for medicine for many years, but a couple of years ago, actually before the grant, expanded it to all the residencies in Cornell, so that we would invite medical students from around the area to come and visit and learn about us. We recruit at the Minority Medical Student Organization, national organization meetings and regional. We also have a welcome back event for minority applicants to come when they are trying to make up their mind where they're gonna, what they're gonna put on their match list, to try to lure them one more time. And we have visiting clerkship for minority 4th-year medical students. These are some of our beautiful residents and one of our faculty in the background in one of our planning meetings. That's Make Your Match, and that's our GME Welcome Back. And we want to increase and support minority faculty at Cornell, including another new mentoring program, which is called Mentoring Circles. This is a peer-near-peer program and the way the kickoff has been actually associates that are like right on the cusp of promotion to try to augment our professoriate level faculty. And then the notion is that as we train our first cohort, then they'll, in our second cohort, work with our junior faculty. And then we're going to have something called Scholars in Health Equity, which are about to start, which is both research scholars in health equity, small grants for people that either haven't necessarily had health equity as part of their research portfolio, or augmenting people that are interested in these areas to add that to their, to sort of have mentoring in this area to then be able to submit for a larger grant, or education scholars in health equity, because many of us are interested kind of ideologically in like, we should all have equity and all that stuff, but it doesn't necessarily mean that we have necessarily grasp of the giant literature about health disparities and health equity and cultural competence and all that stuff, and that if we want to integrate it into our teaching at the bedside or in basic science, how do you do that? So we are inviting clinician educators to join the education scholars in health equity and have training, and their capstone will be an innovation in their educational efforts to integrate health equity content. And we have a health equity fellowship, so any residents that are interested in health equity, be aware our first fellow is starting in a few weeks. So in conclusion, right under the wire, I think we all believe that enhancing the diversity of the health workforce is important for the health of the nation, and that systemic exclusion and disadvantage largely account for the inequities, but that we can and should make aggressive efforts in this area, and that we can create the healthcare workforce of the future. So I probably have 1 minute for questions, I think, because it's 8:58. But I really, again, want to reiterate my my gratitude for being invited to meet with you and to talk about something that's near and dear to my heart, and to honor the memory of your dear friend who lives on in your work. So congratulations to you.
We'll perhaps take one or two questions. Any thoughts from the audience?
Anyone?
If somebody says they're African American on their application, is that it? Are they African American? Because there's just recently in the newspaper this guy Skinner that's been cheating, getting people in. He'd tell them to put down that they're African American, and de novo, the Ivy Leagues would take that.
Oh, you mean the guy that was indicted?
Congressman who said she was Native American, and it turns out it's like 1 in 1,000 or something like that.
Singer, yeah, that whole scandal was really crazy.
So how do you know that somebody's African American if they apply? If they just say I'm African American?
It's an interesting question because, of course, we don't. There is no way to exactly know by DNA. It's a cultural construct, race and ethnicity. But I guess the way I think about it is that most of us identify with whatever group that we identify with, and I guess the most important thing for me is people's interest in trying to serve the underserved. I guess that's my main priority.
The New England Journal of Medicine's got an egregious mistake that's been made, which is published, of a transgender person who is a pregnant male. And they totally missed the diagnosis of a distress, which was lost pregnancy, because they didn't look at it. So do you have any transgenders, for example? Is there a program, do you try and get transgender people?
Our program does not specifically focus, but I think that issues that are faced by LGBT students and residents and faculty can parallel some of the feelings of isolation and exclusion, and so I certainly am interested. We're actually about to start a mentoring cascade also for LGBT students. And our dean is really interested in the model for all students, because I think the notion of supporting all students, whatever their background, is the thing that I think we all value the most.
Great. Thank you so much. I think Dr. Morales has given us much to reflect on. We'll look forward to talking as the day goes on.
Thank you.